I am Dr. Dee Jordan, a postdoctoral research fellow at Harvard Medical School in the Department of Global Health and Social Medicine and a council member for the American Geographical Society. And I will be moderating the following panel on Geography of Health Equity, examples from around the globe. So let me introduce our panelists. Dr. Matthew Bonds is an associate professor of global health and social medicine at Harvard Medical School and co-founder and scientific director of Pivot. He holds a PhD in economics and a PhD in disease ecology from the University of Georgia. His research focuses on the ecology of poverty and economic development, infectious disease modeling, and the science of implementing global health delivery systems. Pivot works with the Madagascar government to establish a district-level model health system. Then we have Dr. Anup Jain, is the founding director of Sanitation and Health Rights in India, SHRI, an organization that fights to eliminate open defecation throughout India. Anup started the organization with two colleagues in 2012 as a response to India's sanitation crisis. To date, SHRI operates 8 community sanitation facilities in Bihar and Jharkhand, serving over 6,000 daily toilet users. Dr. Jain received his MPH from Tulane University and his Doctor of Public Health from UC Berkeley. He is now a postdoctoral researcher at Harvard Medical School. Dr. Danae King is an associate director in the Robert D. Bullitt Center for Environmental and Climate Justice at Texas Southern University. She enjoys working with community leaders on environmental justice projects designed to address community-identified environmental health concerns in underserved people of color communities in Houston and along the Gulf Coast. Dr. King is a graduate of Texas Southern University, and she received a PhD in environmental science and toxicology from the University of Texas Health Science Center, Houston, School of Public Health. First, we'll hear from Dr. Matthew Bonds.
Thank you for giving me the chance to talk with you all today. My name is Matt Bonds. As Dr. Jordan said, I'm an associate professor in the Department of Global Health and Social Medicine at Harvard Medical School, and the founder and scientific director of Pivot, which is a rights-based healthcare organization that is focused on developing a model with the government around universal health coverage. So today I want to talk a little bit about the role of Pivot's partnership with the government and integrating science and clinical programs, and the role of geography in helping reduce geographic barriers to care and general health inequity. So this is Madagascar. This is a village in the Fonadine district where my colleagues and I work now. Many of you know Madagascar is an island nation, about 22 to 25 million people off the coast of Africa. It's technically considered part of the WHO Africa region, part of sub-Saharan Africa. Ethnically, it's mixed. It has some Asian influence and African influence. This is a Fonadine district here on the right. It's in southeast Madagascar. And the star here is the area of Ranamafana, which is actually the area where there's a lovely national park as tropical rainforests and a UNESCO World Heritage Site where we actually have our headquarters. This is, as I just mentioned, a typical village in that district. About 8 years ago, I had my first experience working in Madagascar, actually visiting Madagascar, and I came across a health center. This is Ranamafana Primary Care Health Center. At the time that I was there, this was actually 2011, so 10 years ago. And I had been working with the organization Partners in Health in Rwanda at that time. And during that time had witnessed a lot of progress in the health system, along with the rest of the world's progressing, partly inspired by the Millennium Development Goals. And here in Ranamafana, Madagascar, 2011, there was a girl around 8 or 9 years old lying on this bed I didn't take a picture of her, but I did take a picture of the space, and she had malaria. She had agonal breathing. She had cerebral malaria. She was nearly comatose. She was about to die. And she was in this health center where there was a physician. She was receiving no treatment. This is a decade after the Millennium Development Goals were set, after the Global Fund for HIV, TB, and malaria. This is well after we know how to solve these problems like this. And so the one question that arises is, why does this happen? We've since learned that in Acknowledgement district, there are many people like her. The under 5 mortality rate, probably of dying before you're 5 years old, in the Acknowledgement district in 2014, when we later did a proper baseline study, was 1 in 7. The lifetime maternal mortality rate was 1 in 14. So this experience had compelled us to pursue the question of how to advance actual universal health coverage. So the central question here is, why did this happen? Why does someone who, why does treatable illness not be treated when the costs are low and the technology is actually quite straightforward? And in fact, policies are in place and there's some international and national movement. So why does it happen? So we created this organization, a non-governmental organization, Pivot, to partner with the Ministry of Health to help solve this problem. This is called, in some circles, the no-do gap, and to actually establish this district, Finding District, as a model. So Finding District, you've seen a few maps of this already. This is the district. These are communes. These gray areas are different municipalities, essentially, within the district. And the central philosophy of the model district is that we work with the partnership with the Ministry of Health to design, deliver, actually implement healthcare programs along with those policies and design, and collect data and tighten those feedback loops meaningfully so that the data are used at a time till it's relevant to decision makers, whether those decision makers are staff or clinicians or political actors in the government. This works at all levels of the health system. So the District of Acknowledgement is very typical of districts throughout the country of Madagascar. It's also very typical, this health system structured really similarly across much of sub-Saharan Africa, in that in a single district, about 200,000 people, there's a single district hospital where secondary care happens. There are many primary care centers that are organized at the level of a municipality, so 1 primary care center or 2 per municipality. And then there are community health workers and community health systems, so that local lay community health providers who live in the villages where they're working are able to provide some primary care services for maternal and child health. So since 2014, this organization was started, Pivot, and the kinds of programs that we do are across the board. They're comprehensive health system strengthening. So these are child health programs, infectious disease programs like tuberculosis, malnutrition, maternal health, and social programs and emergency referral programs. We even have ambulances here, motorcycles, trucks as ambulances. And these kind of clinical programs are combined with what we call readiness. So readiness is providing the capacity across clinical interventions, such as infrastructure, human resources, finance, supply chain equipment, quality programs to improve the quality of care, and the kind of data systems that are embedded into the health system for routine work and record keeping and registry information. And so what our unique proposition has been is when we take those fundamentals, the fundamentals of health system strengthening, providing the horizontal and the vertical programs, the horizontal meaning the readiness, the vertical meaning the clinical programs, you combine those together with the Ministry of Public Health, and also collect enormous amounts of information, to collect the kind of data that allows us to understand whether or not clinical programs are being met, whether patients are being served, whether there's breakdowns in the supply chain, et cetera. And so that there's a learning process so that the kind of breakdowns that we saw in the case of the girl in 2012, those are able to be identified and resolved. So we track actually 800 We've treated 800,000 patients since we started in 2014, and we actually track about 800 individual health indicators. These are routine indicators that sound like a lot, but they actually are tracked. In fact, these are the kind of data that are collected routinely in health systems all over the world. What we do is we collect the information, keep it in a database, and allow real-time indicators to be present. So in addition to the health system data, we have a range of epidemiological designs to help track population-based data. So not only we're seeing what's going on with patients in the health system, we're seeing what's going on with patients outside of the health system through representative household surveys. So we have a longitudinal cohort tracking about 9,000 individuals in the district, returning to the same individuals. Some are inside the initial catchment area, some are outside, and we're using standardized questionnaires that are doing them nationally. So the demographic and health surveys and things of that nature. And with that kind of data, we get to do things like this. We can map changes in access to care. This is vaccine coverage. The solid line is in our intervention area, and the dotted line is outside of our intervention area. And we've seen major improvements like this, like I just said. And then there's some things that don't improve in the way that we had hoped. So this is under 5 mortality. The orange is in our intervention area. The green is outside of the intervention. On the one hand, you can see that under 5 mortality dropped faster than the comparison area, but they started rising again. This raises big questions. We have all this information. We're doing integrated health system strengthening with the government. We're seeing progress in important indicators like vaccine coverage, but really in fact, the holy grail of health system strengthening is really, I think many would say, under 5 mortality. We're not seeing changes. So what's going on? One answer is geography. So while this work is being done, while the routine systems are being corrected, strengthened, and while population-based data are being collected, in addition, we're doing a deep geographical analysis to understand geographic barriers to care. So this is work that was led by Dr. Felina Ihanta-Malala, who's a postdoc at Harvard Medical School, who's Malagasy, lives in Madagascar. And what she did and her team did is actually map every structure in the district, every household, every primary care center, every community health site, identified every trail in the district. So 20,000 kilometers of footpaths. Almost all of it there's almost no paved roads across the district. And to identify precisely what it takes for people to get from one point in the district to another, modeled it using software from Humanitarian OpenStreetMap and some mathematical and statistical modeling to identify exactly what it takes for people to get access to care. What you can see from here on the right side is the Euclidean distance, other circles. The shade is actually how far things are in terms of the time. And what you can see is Euclidean distance is not the same as the distance along these trails. This gave us really important information. Exactly how long does it take to get to a community health site? The left is a community health site here. The right is a primary care health center. So on the left, a 4-year-old can get treated for malaria. On the right, a woman can get a vaccine or deliver a baby and get treated for malaria. And what we're learning from this program is that not everyone has access to care. Now that we know who's got access to care, where people are living, how far they have to travel, what you can see here is that in our intervention area, that's the turquoise here, folks who live close to a health facility really had access to the strengthened primary care system. Folks in the orange area, the orange those are villages that are outside of Pivot's intervention area where the system hasn't been strengthened. What you can see is their utilization rate, even for is less, even for those who live close to the health facility, aren't accessing much care. But as we go away from the facility at 5 kilometers, 10 kilometers, what you can see is folks even who are in the catchment area of a strengthened system aren't accessing care. So this map tells you, hey, after 5 kilometers, folks do not access care, even when strengthened, even when user fees are removed, even when the Ministry of Public Health policies are being implemented. So why is that a problem? The majority of people live more than 5 kilometers from a health center. So what we're learning here is through geography, through deep analysis, through strengthening the health system, we're learning the limits of the existing policies in place. And we're also learning we're being able to shine a big light on some of the fundamental challenges of a country like Madagascar, 25 million people, actually meeting its own goals of universal health coverage, given the geographic disparity across the population. So in other words, the health system is not designed to reach everyone. So what's the solution here? Maybe it's geographers, right? Maybe that's a part of the solution. I think it is part of the solution, understanding. It's also community health. It's actually programs to implement that get outside of this initial 5 kilometers. So since then, since we had this data, as just an example of how we use data in this model system, we've actually taken that information, we've strengthened community health worker programs. Community health workers are now compensated more, they're trained more. They actually, through a new program with the government, knock on doors and visit every household once a month through what we call proactive care as a response, as a policy and implementation response to the science in the geographic analysis of the work that had been done. So this is the basic summary of my work. So to summarize, the no-do gap presents challenges for achieving health-related development goals that many countries aspire to. Feedback systems of design, delivery, and data are important for closing this gap. In Madagascar, pivot partners with the government to create model system of UHC. Program services do not reach everyone equally with persistent geographic disparities. Community health has since been redesigned, delivered, and evaluated. So in sum, these are solvable problems. We have the right information, we have geographers, we have implementation happening alongside the public system. Good things that happen. Thank you.
Hi, everyone. My name's Dr. Anup Jain, and I'm very grateful for the opportunity to be presenting today on the small area variations in dietary diversity throughout India. Next slide, please. I would like to first acknowledge my partners on this work, specifically the Geographic Insights Lab, which is an interdisciplinary lab based at the Harvard Center for Population and Development Studies. More specifically, Dr. S.V. Subramanian, who is one of my advisors at the Harvard School of Public Health, and our colleagues, Dr. Rockley Kim, Wei-Yu Wang, and Akhil Kumar. Next slide, please. So this is an image from one of the communities where I work in India. It's a village located in the Saharsa district of Bihar. And as you can see, there's a child here. There's very high rates of malnutrition. Very few people have sanitation facilities. Very few people have safe drinking water. And certainly people do not have enough money for adequate dietary diversity. So people are facing a lot of concurrent social and asset deprivations in their lives. And as you can see, unfortunately, very poor living conditions as well. And so I started working in India in 2010, and I started working on nutrition projects, actually, because I knew that there was a very high prevalence of anthropometric failure throughout India, so stunting, wasting, and underweight. And what I wanted to do with my colleagues was address that through sanitation. We believed and continue to believe that improving access to sanitation is one way in which you can diminish a child's risk for anthropometric failure. And certainly there's evidence suggesting that that is the case. And yet, as I noted, and just a few moments ago, and as you can see from this photo, the lack of sanitation is just one of many deprivations that families face. And so what my colleagues and I wanted to do is start mapping anthropometric failure and dietary diversity throughout India as well. Next slide, please. And so child malnutrition remains extremely prevalent throughout India. Child malnutrition is commonly measured through child anthropometry and anthropometric failure. So height for age Z-scores, weight for age Z-scores as examples. And so approximately 39% of the children in India are stunted, so they have less than 2 standard deviations of the World Health Organization sort of normal score, below the height for age Z-score. And the prevalence rates for other forms of anthropometric failure are also very high for stunting and wasting. And approximately 30% of the world's stunted children live in India. And so one of the things that we know from a geographic perspective is that there are these really wide variations between populations. And so what do we mean by that? So if you look at the 2 states that I've highlighted here, Bihar and Jharkhand, where I've been working for the better part of 10 years. So while the national prevalence of child stunting is 39%, in Bihar it's 48%, and in Jharkhand it's 46%. So above the national rate. And so if you were to go to South India, in states such as Kerala, it's much lower. It's 21%. It's still certainly very high, but you can see that there's these big disparities between states in India. Another thing we know is that there are within population variations in child anthropometry. So what do we mean by that? So a little bit of context. So India's geography, the units that we really care about are states, analogous to states in the United States, and then districts, which are analogous to counties, and those are nested within states. And then nested within districts, we have the urban and rural clusters. So these can be peri-urban areas or villages, but these are then nested within the clusters, nested within the districts, which are then nested within the states. And what we know for anthropometric failure is that not only do we have the between state variations, we have within state variations. So different districts within states have different prevalence rates of anthropometric failure. And certainly when you go one level below that, within districts, we see anthropometric failure varying between clusters, so between urban and rural clusters. So we can see that the finer and finer we go in terms of granularity at the geographic scale, we're still seeing these variations in anthropometric failure. And what we wanted to do as an extension to this is start looking at dietary diversity. Next slide, please. So we have all of this sort of background knowledge on anthropometric failure, and what we don't know is the extent to which dietary diversity also varies between and within geographies in India. So dietary diversity is another very important indicator of malnutrition, and it's often not thought of in the same way as anthropometric failure. And it's important because it highlights the nutritional deficiencies among children who might not be experiencing any form of anthropometric failure. So you could have a child who is not stunted and yet does not have adequate dietary diversity. And then it actually points to the specific food groups that are missing from child diets. So for example, eggs, a child might not be getting enough protein through eggs or flesh foods, or enough fruits and vegetables. And so it's really important for us to understand these between and within population variations in dietary diversity, primarily so that we can start informing policies aimed at addressing the heterogeneity in child nutrition outcomes throughout India. Next slide, please. And so I won't spend much time on our methodological approach, but what we did was we used the World Health Organization's minimum dietary diversity scale, which goes from 0 to 8, and it includes 8 major food groups. A score below 5 means that a child does not meet the minimum dietary diversity. And so we estimated the following 3 equations to obtain geographic residuals, cluster predictions for the percent of children not meeting the minimum dietary diversity in clusters, and then the same in district. So equation 1 here is a 4-level, multi-level model in which we model the odds of a child not meeting the minimum dietary diversity. And the parameters of interest here are the U, V, and F terms, which are just the error terms for urban and rural clusters, districts, and then states respectively. And then what we do is we use those values to estimate equation 2, which gives us the prediction of the percent of children who do not meet the minimum dietary diversity in each cluster. And then we repeat the process in equation 3, and we do it for districts. And so what we end up doing then is we find the standard deviation of the cluster level predictions within each district to quantify the small area variation. And then we correlated this with the district level predictions from equation 3 to quantify geographic inequality. Next slide, please. And so what we have here are the maps that sort of correspond to these findings. On the left panel, we have the mean percentage of children who do not meet the dietary diversity score, minimum dietary diversity per district. And what you can see is that children who do not meet it are clustered in West and North India. And on the right panel, we have the standard deviations of the clusters within each district. And what you can kind of see is that these are inversely correlated. And so if we go to the next slide, please. So we actually chart this correlation, and what we see then is this negative correlation, and there's a reason why this matters. So the Indian government, there's 640 districts within India. There's 1.3 billion people. So understandably, the Indian government is trying to understand which geographic areas to prioritize. And so they have prioritized districts and in particular, those districts that are performing poorly. And yet what our plot here shows is that even in districts where there's a low mean number of children who are not meeting the minimum dietary diversity, there are clusters within those districts where the percentage is much higher, actually. So we can see this within district inequality is really noticeable when it comes to minimum dietary diversity. And if we go to the next slide, we can actually see this with specific food groups as well. So I just picked eggs here. I really like eggs. And so we see with eggs a similar sort of pattern. High percentage of children in West and North India are not getting eggs and the nutritional value associated with eggs. And we see this inverse relationship with the standard deviation within districts as well. So if we go to the next slide, again, we see this negative correlation. So by and large, the districts in India, there's a high percentage of children who are not eating eggs. And yet, even in the districts where there is a lower percentage of children not eating eggs, there's still this very pervasive inequality. And this really points to why the Indian government and multilaterals and the World Health Organization should be very careful in which geographic level they select, because we understand from a practical consideration the importance of selecting districts. And yet, if you look within those districts, we're still seeing this very high degree of small area variation. Next slide, please. So in conclusion, inadequate dietary diversity or dietary diversity in general is an important indicator of child malnutrition. Quantifying the small area variations is important, as it can help elucidate between and within population variations in dietary diversity. And not only does it point to the regional inequalities, but the within region inequalities. By and large, consistent with previous literature, we show that there's a high percentage of children who do not meet the minimum dietary diversity in West and North India. And districts with a low percentage of children not meeting the MDD might still have a very high degree of within district inequality. And this remains true for when you look at specific food groups such as eggs as well, and points to why we need a finer level of intervention at a lower geographic scale. Thank you so much.
Hello, I'm Dr. Danae King. I'm an Associate Director of the Bullard Center for Environmental and Climate Justice at Texas Southern University. And today I'm going to share with you about a collaborative project focused on vulnerable communities, COVID, and public transportation. We'll discuss areas of Houston that are most vulnerable. We'll talk about who was impacted by COVID, and then we'll share some residents' perceptions of public transportation use during COVID. This image shows you where people of color live in the Houston metropolitan area. And the take-home message really is that African Americans live in kind of the northern and southern parts of Houston. Our Hispanic and Latino residents live in northern and eastern parts of Houston. And then for the most part, our white residents live on the west sides of Houston. And I think it's important to note that while there are a few areas where we see kind of the mixing of colors, for the most part, the city of Houston is a very segregated city. So where are the vulnerable communities really located in Houston? The image on your left shows you where people of color live. And basically, the darker the color, that means that more people of color are living in that area. And you'll see that for the most part, people of color live on the eastern sides of Houston. And then in terms of social vulnerability, this is an index used by the CDC really to kind of determine how to prepare and respond to disasters. And so you'll see that those areas where most people of color live are also the areas where we see vulnerable communities. This image shows us once again where people of color live, and let's pay attention to the eastern parts of the city of Houston. And here, the image on the right side shows us our total respiratory hazard quotient. And basically what that is it shows us where communities are more at risk of poor air quality. And the air quality issues seem to concentrate more in the eastern parts of Houston where people of color live. Here we're going to look at where COVID cases occurred and also where COVID deaths occurred. And it's important to point out that this study was really done at the early parts of COVID, of the coronavirus and the pandemic. And so we really focused on the first 6 months as it related to data. And so COVID cases and COVID deaths, we see some similarities, but what's most important is that we see the same trend as it relates to the east end of Houston. And so the last image we're going to look at is a transportation index, demand index. And this basically tells us where transportation is needed most. And so you'll see that on the east end of Houston, there are darker colors related to more need on that side of town. And that once again relates to where people of color are concentrated. So we use these 5 data points, these 5 indexes basically to develop what we called a priority community map. And so this map was used to help us select communities that were considered vulnerable, one for COVID in terms of cases and deaths, and also for identifying areas where transit or use of public transportation was most important. And so this is the map that comes up from the 5 indexes. And so the pinker color is basically referring to communities with high priority. And the yellowish or blue colors relate to communities that were considered low priorities. And the communities outlined in the black line show communities that were selected in terms of priority communities for our project. And so those communities are the Cashmere Gardens communities, 3rd Ward, which is where Texas Southern University is located, and also the Gulfton Sharpstown communities. So these communities were selected, and then you'll see on the end a comparison to Houston as a whole. And so for the Cashmere Gardens Fifth Ward community, 34% of the residents live in poverty, 97% are people of color, and 6% are workers who use transit to commute. And then in the Sharpstown Gulfton community, we see 29% of the residents live in poverty, 91% are people of color, and 6.8% are workers commuting by transit. And then Third Ward, 31% of the households are in poverty, 82% of the residents are people of color, and then 9.4% of the workers use transit for commuting. And when we think of comparing that to the city of Houston, whereas only 14 households are living in poverty, we are a city with 70% people of color and very low percentages of workers who commute by transit. So we are a individual car driver community with lots of traffic and air pollution caused by moving goods and moving people. And so as we selected the priority communities, we conducted focus groups with transit riders in these communities. We used community leaders to facilitate virtual focus groups and really learn about transit riders' perceptions of public transportation and what they thought about using it during COVID. We ended up with a total of 30 community members participating in focus groups, and these were some of the findings. And so participants told us that they used public transportation such as bus, and Metro is our public bus service. They used the light rail, they used bikes, they even used things like Uber and Lyft. They used public transportation because they lacked vehicle ownership, and some people said they used it to avoid traffic and congestion. Residents talked about using it because of its convenience. It's affordable, it's efficient. They felt like it was reliable, convenient, and for some families, it was a necessity. And then people use it to connect. Basically, they connect with other people, and they also use it to connect to opportunities and resources. And so in terms of opportunities for improvement, transit riders felt like there were some opportunities to improve equitable access as it related to bus routes and also bus shelters and ADA compliance. There were definitely opportunities for improvement as it related to crime and COVID precautions. And remember, we were doing this at the early onset of COVID. And then there were opportunities to improve negative perceptions of public transportation use. And so these were some of the quotes from residents. They talked about they use buses for everything in their house, whatever it might be. One resident said, "I think if we continue to take precautions, both the passengers and the bus drivers, public transportation could still be used comfortably." They thought they need masks, sanitizers, and also using social distancing. And then one resident said one of the reasons people should use public transportation instead of driving is really to help with reducing asthma, climate change, and fatalities on the road. And so the findings from the focus group suggest that our community participants without access to a vehicle continued using public transportation and primarily for work purposes. And so these participants were our essential workers. They were the people that relied heavily on public transportation during the COVID shutdown that maintained our city and kept us going. And so it is very important to identify vulnerable communities, one, to prioritize funding, and also to prioritize resources that are critical for enhancing the quality of life for all Houstonians. And so these are my project partners. This work was done along with Air Alliance Houston and Link Houston. Air Alliance Houston is a nonprofit that advocates, obviously, for great air quality in the city of Houston. And then Link Houston is a nonprofit advocating for transit equity. This work is highlighted in a report called COVID and Public Transit in the Houston region. And The work was funded by the Urban Institute via the Robert Wood Johnson Foundation. And thank you.
Great presentations, everyone. It was so fascinating to see your work, such great research on truly complex issues that have implications on equity. I should let you know that this panel was intentionally brought together. And the reason why I said it was intentional, it's in the sense that you are carving out space that might not be easy for you to occupy. Effectively, you are navigating spaces and places that are contested for a myriad of reasons. For instance, Dr. King is an African-American scientist studying environmental justice in a majority conservative state in the US within a county with innumerable environmental justice concerns. Dr. Jane is an East Asian scientist doing work in global health. And this field and the space of global health is very global North and Western dominated. But Dr. Jane is using his opportunity to expand the research and our knowledge on India. And Dr. Bonds is a white American scientist conducting research to help reduce inequities in remote rural Madagascar. I consider each of you to be systemic disruptors, as your work has the potential to shift the status quo, address systemic issues, and reduce structural barriers in order to make health more equitable. So I have a few questions for you. Tell me what drives and motivates you to do this work? And we'll start with Dr. Jane.
Thank you, Dr. Jordan. I appreciate that question. There's a few things that motivate me to do this work. I remember when I started doing this work back in 2010, I was 24, just a couple years out of undergrad at the time. And we were trying to do a very rudimentary sort of household level survey to understand the extent to which households in our communities have access to a toilet. And we were at one particular household, and there was an elderly man who was there with a very badly infected foot. And he was asking me what he should do about it. And I had zero medical training. I still don't have any medical training. And yet he looked at us as I was with my colleagues from the US, and he looked at us as though we were some sort of expert. And I've never forgotten that. And it's motivated me to want to become an expert in all things relating to health inequity in India, because I think the least we can do is be the best service providers for the folks that we care the most about. And so for us to become the best, we have to understand at a very high level what inequity means in our context. I mean, I think most of us have a very sort of high level understanding of inequity, and yet my opportunity to be a researcher at Harvard has allowed me to push that even further and look even deeper under the hood of what it means for inequity to exist in India. And so it's really important. I think that's my core motivation is I know that we serve fathers and mothers and children and grandparents and uncles and aunts, in India on a daily basis. And I take it in the same way when I go to see a doctor here. I want them to be the best expert. I want, as a public health practitioner, I have the same expectation of myself when I'm providing services to people in places such as India.
Thank you for your response. Dr. King?
I do this work because the communities that are often faced with environmental racism are communities with residents who look like me. And so I spend a lot of my time working with community leaders who are resilient and passionate and are always on the forefront of making sure that people are aware of what they are being impacted by, whether it be industrial pollution sources or now more in the Gulf Coast and particularly in Houston, the impacts of climate change. So the results of extreme weather events such as hurricanes, and more recently with the effects that we have from the winter storm that we were not used to dealing with. And so I do a lot of this work because it is important to make sure that all of us have equitable access to a healthy and safe environment, and also equitable access to recovery from disasters that occur, whether they be man-made or natural disasters. This work is important, and we all deserve to have a great quality of life.
And Matt, Dr. Bonds.
My reasons have changed over the years. You know, when I first started doing this work, my motivation was to connect. It was there are problems, and there are lovely people everywhere, and if there's a way to address problems and the spirit of dignity and respect and connection, then I was there for that, I would say. Over time, it's different. I'm an academic now. I'm a professional academic, and to me, what riles me up is cognitive dissonance. So there's problems that persist. There's an industry around that produces information and evidence around that. There's global organizations and institutions, and I don't think it's working as well as it should. And so my motivation is, wait a second, like, experts say this, problems look like this, why does that keep on happening? And that's a real question. You know, it's to try to fill in that gap.
Outstanding, remarkable responses from you all. My next question is a bit more on the nose, given that this is GEO 2050, towards a more equitable future. My question is, in your work, though we saw the maps, I want you to share with us your own perspective of how you feel geography plays a role in your research, informs the outcomes, or if geographers need to lean in a bit more. And for that question, we're going to start with Dr. King.
Thank you, Dr. Jordan. So geography plays a significant role in the work that I do. And I'm going to share a great example. So we do work as part of an HBCU CBO Gulf Coast Equity Consortium. And as part of that consortium, we do work with Dr. David Paget, who is a geographer from Tennessee State University, the other TSU. And so Dr. Paget works collaboratively with a community in the Pensacola, Florida area. In that area, though, the community is faced with burrow pits, which are basically areas where they take all of the sand out of the area, and then at some point they fill the area back in with unwanted things, so it becomes a landfill. David Paget worked with the residents in that Pensacola community to create a map that demonstrated how many burrow pits were concentrated in a certain geographic area. And he also helped them to display flooding that occurred in that area and how that flooding of those contaminated sites might impact other communities downstream of their community. After presenting that map to the county commissioners in their area, there were lots of changes that occurred. One, they created an environmental justice working group that the community members now serve on. Two, they decided that before permits were reviewed or even recited, they basically had to go through an environmental impact assessment. And so that decreased the number of those sites that were being placed in that community. And the only reason that really happened was they were able to visualize the effects of the burrow pits in that community. So communities and researchers alike, being able to work with geographers certainly helps us in the environmental justice and climate justice movement.
Dr. Bonds?
at Pivot, we say what makes our nurses different is that they care for people that they've never met, and the way they do that, the way that we do that, is to identify people who come into the health system, identify people who do not come into the health system. And how do you do that? You have to find them. And I'm someone who believes, who really appreciates the complexity and multiple dimensions at play of determining health equity. I've really come to believe that geography is one of the most powerful ways that capture a lot of information, honestly, about a particular issue or problem. And so for us, that boils down to, oh, some people are getting care and some people are not. Where are those people? Well, how do you do that? You find someone who knows how to locate things. Geographers.
Dr. Jane?
So my family and I, we immigrated to the U.S. in 2000, and I remember when we moved here, we were either going to move to New Orleans or Houston, and we ended up in New Orleans. And I remember going through high school, on Saturday nights, I was kind of a nerd. I would sit at home and do my homework, listening to WWOZ radio, DJ Soul Sister. And I became obsessed with sort of funk and disco music from the 50s, 60s, and 70s. And that's carried with me to this day. And I often think, if I had lived in Houston, I don't know if I would have had that exposure. And I think about just how important that decision was in shaping who I am as an individual. And I think about the communities where I work in rural Bihar. The district capital, for example, might have drains and piped water. And if you go 5 kilometers, 3 miles west, north, east, or south, you'll be in these very rural hamlets that have nothing. And how that shapes who you become later on in life. And so geography is not only about where you are sort of cross-sectionally at a moment in time, but it shapes who you are 10, 15, 20, 30 years down the line. And so I think that geography is a really, really useful tool and discipline. And if we can start coupling it with understanding sort of how it affects people over the life course, I think that we will really be maximizing the potential here to understand how social determinants in a certain area influence and shape the outcomes that we really care about over people's lives.
Once again, great responses. The insight that you all are providing to how geography plays a role in your work, the personal stories, and how it impacts the outcomes of your research, kind of reinforces the necessity of this field and practitioners of that work. I mean, if you can't locate the people, how can you serve them, right? You have to be able to visualize the problem to make it plain to the people who are in the decision-making capacities in order for them to do something. And sometimes it's these personal impacts that change the dynamic of who we are and what we focus on. And geography plays a role in that because knowledge is situated. So my last question for you guys is, how do we move health towards a more equitable future? And for that question, I'm going to start with Dr. Bonds.
That's a really big question. I would start by saying, by noting what I had said in my last comment, which is it's really important that we think about, from when I say we, I mean decision makers, I also mean implementers, I mean the whole value chain of services. We think about people who we don't meet, right? We think about people, and so I've often thought, like, one of the approaches that I think is really helpful in Madagascar that I would love to see done more often in the US, but Dr. King showed us a little bit of how that's done in the US, is we don't think about the health problems not as what's in the hospital, but what's in the population, right? Where are the problems, right? Where are the challenges? Where is the inequity? Go there. And I think as a starting point, I think if that's the lens, then to me, that's foundational to practical solutions and all other things. So I would say identify where the problems are, think about it from that perspective, and then build programs around there. Obviously, there's a gazillion other approaches, but that's where I would start.
Dr. King?
So I agree with Dr. Bonds. I think that in order for us to really understand health equity, we really need to do things on a place-based level. And so that involves you really understanding where people are, where are vulnerable people located, how are they being impacted, what's really impacting them, and not looking at it from an individual stressor perspective, but from a cumulative stressor perspective, because in a community, you are impacted by cumulative exposures as it relates to environmental justice. So you may be exposed to an industrial pollution source. You may be living in a community without fresh fruit and vegetables. You may not have access to a hospital or to a primary care physician. And so there are these maps that just kind of overlay, and you have these cumulative exposures, which means that solving the problem is quite complicated. So visualizing and really understanding what's happening on a place-based level, and then working with people who live there to solve the problem. So taking their expertise and working with decision makers, elected officials, public health officials, to really develop community-driven solutions. That's my thoughts.
Dr. Zhang?
I think so much of it, Dr. Paul Farmer and other liberation theologists who've written a lot about this have spoken at length about the idea of pragmatic solidarity. So understanding that there are these systemic causes that lead to certain health outcomes. So poverty, being the biggest and most obvious, for example. And so in thinking about my own work in India, one way in which poverty manifests as an impediment to sanitation ownership is people don't have enough land to build a toilet. So they own 370 square feet of land on average. And this is in rural India. So they don't physically have enough space to build a toilet. And yet, so what we do as an organization is we provide shared sanitation facilities, that these public toilet blocks, so that people from different households can come and use it. Is it an ideal solution? No, we want everybody to have their own toilet in their own home, and yet we're providing the best solution that we can today, given the circumstances, and we continue to elucidate and shed a light on the systemic failures such as poverty that prevent people from owning an individual toilet. And so to answer your question about how do we ensure equity in health, I really think it's two parts. It's understanding at a deep level what the big systemic issues are, having a set of policies that address those over time, and then providing the immediate solutions that people need today, and making sure those are the highest quality services that we can provide, that everybody deserves.
Outstanding. I want to, on behalf of the GEO 2050 Planning Committee and the American Geographical Society, thank you for your participation on the Geography of Health and Equity, Examples from Around the Globe panel. Go safe and be well.